Okay, so for now I will present one interesting case out of our cohort. As you know, this case, there is no clear or white and black. We managed our patient, and we love to hear from your expertise, like your opinion and suggestion for this case. So our case, just because we are very short on time, this is about 40-year-old male, known case of ankylosing spondylitis. Can I go back? Based on following feature: bridging syndesmophyte, grade 3 sacroiliitis, peripheral severe polyarthritis, inflammatory back pain, active inflammatory sign in MRI and sacroiliac joint and spine, active synovitis on ultrasound, and very high inflammatory markers. So he presented with very severe inflammatory back pain, significant peripheral arthritis, tender and swollen joint were like more than 10 joints. And we used to inject the patient many times during each session. And he had an ASDAS of more than 5.5. Though this is a problem here. What I presented, that is easy case to manage, a typical case of ankylosing spondylitis. But this patient was diagnosed, actually just to mention that first time we saw this patient, he was on oncology bed. He's not known to us before. So when we saw him 2016, by end of the year, the patient had diagnosis of adenocarcinoma. CT scan of chest, abdomen, and pelvis showed rectosigmoid mass with early invasion to the adjacent fat and few regional lymph node. There were no feature of metastasis. Patient was operated and mass resected. And post-resection 2017, CT then showed no residual tumor or distant metastasis. Again, CT abdomen and pelvis in April 2017 showed no gross residual tumor or local recurrence, no lymphadenopathy. CT chest of 2017 August showed again no metastasis, no tumor, no lymphadenopathy. The liver showed like demonstrate homogeneous enhancement with no focal lesion. So there is no suspicious bone lesion. So the impression was the patient on remission. Bone scan was done in 2017, was normal. CT chest of 2018 normal. CT abdomen pelvis 2018 was normal. Patient failed everything, requiring NSAID as he could. We injected him many times, and the patient failed sulfasalazine, and he has really ongoing inflammatory back pain. So that time, after 2.5 years of diagnosis of cancer, we thought about should we start biologic or no. Okay, so as you know that to start biologic, in this case of active malignancy not exceeding 5 years, we have to discuss it case by case by his own oncologist. And this is what we did. Actually, we had the clearance from the oncologist, his staff, and she was clearing our patient, and she advised to start treating patient with biologic. And then we discussed the case with the patient, because we should respect his opinion and his preference. So the patient was strongly accepting the idea of starting biologics. He is not accepting the way he lives. So from the patient point of view, he was clear for biologic, and staging of cancer, he was clear for the last 2.5 years. So at that time, we have to choose. Like, we have two approved medications, either anti-TNF or IL-17. So that we know the evidence mixed with respect to the risk of lymphoma, leukemia, and solid malignancy, though the majority of the recent observational studies say there is no confirmed increased risk of malignancy with anti-TNF. But we know that the FDA has issued several warnings regarding such risk, and most of the anti-TNF US boxed warning. So challenges in establishing the true magnitude of the risk, if any, between the TNF inhibitor use and the development into malignancy is still not clear. So it came to my mind, like, why wouldn't go the other way with secukinumab? At that time, I was lucky that I found one study, like it's pooled analysis of 10 randomized trial, but it was mainly based on the psoriasis patient, not ankylosing spondylitis. But we know that psoriasis patients, they have higher risk of cancer, and there been a concern over the risk of lymphoma and psoriasis, and this is was like annoying to me that T helper cell and T helper associated cytokines have been shown to have both anti-tumorigenic and pro-tumorigenic function. And so studies in patients with psoriasis have shown an increased risk of non-melanoma skin cancer and solid malignancy like liver, esophagus, and oral cavity cancers. So as I mentioned, this is a pooled analysis of 10 for studies phase 2 and 6 phase 3 randomized double-blind clinical trial. About 4,000 of patients were analyzed. Mainly they received placebo, IL-17 inhibitor, or etanercept. So any male patient or female more than age of 18 was included, even if he received 1 dose of any medication. And safety analysis was conducted, as I mentioned. Just talking about IL-17, 2,751 patients were exposed to secukinumab for more than 24 weeks, and 1,641 exposed for secukinumab for more than 52 weeks. So this is the data here. This is the analysis. Just to cut it short, like less than 1% of the patient received secukinumab, any dose developed cancer. Most of it was non-melanoma skin cancer, and about, again, 0.68% of patients receiving etanercept developed cancer, and 1.5% of the people received placebo developed any kind of cancer. So looking for the percentage, we found that secukinumab and even etanercept a bit lower than a placebo. So in summary, there was no indication that treatment with secukinumab increased malignancy risk. And just to take a look for the efficacy of secukinumab on patients with ankylosing spondylitis, I don't want to waste a lot of time. We know that secukinumab reaching about 62 or 73% of remission on ESAS-20 up to 52 of weeks, and ESAS-40 reaching about 50% on dose of 150. And the efficacy is sustained for 2 years, 3 years, and even for 5 years of treatment. A very important slide to me this, because our patient is anti-TNF naive. So this is first biologic. Data on secukinumab said like the patient achieving the remission on ESAS-20 reaching till the week of 156, 72%. This is very encouraging. Same for ESAS-40, we see the patient anti-TNF naive treated with secukinumab till the week of 156, reaching the ESAS-40 remission up to 64%. So at that time, after we discussed with the whole team, the patient, we started, and by the way, we consulted one of our senior consultant, Dr. Hussein Halabi. I saw him in the corridor in Jeddah, so I took his opinion. So we started on secukinumab 150 milligram without loading dose. I don't have enough evidence that I didn't pick the loading dose, but there is a few slides, maybe I removed it, that patient with psoriasis achieved good remission on without loading dose. So I'm very happy to present this data now at the week 18 of therapy. Patient showed great improvement. The BASDAI came from 7.6 down to 4.2. The SDAS came from 6.5 to 3.4. Tender joint 8 to 3. Swollen joint 6 down to 2. ESR improved from 55 to 17, and CRP from 66 only to 6. So the patient showed good improvement, but still he is not on full remission. So we did the CT scan, abdomen, pelvis, and chest in January 2019, just recent, and showed no lesion, no metastasis. Bone scan came to be normal, so the question here. Patient showed improvement. There is no feature of metastasis or relapse, and the patient still not in full remission. Should we start tapering the dose? Should we keep the same dose with a close observation, or we have to stop and observe? Maybe this is back to how we taper the management in case of partial remitted patient. So maybe this is open for discussion, opinion, because we don't have solid answer for this question. We have other interesting case out of the cohort. Can we proceed, Dr. Hanan? Just 5 minutes. Okay. So the case 2, this is a patient, 24-year-old, diagnosed as a case of seronegative rheumatoid arthritis based on prolonged early morning stiffness, peripheral arthritis, elevated inflammatory marker. Patient treated with methotrexate, not responding, orally escalated to the sub-Q injection, 25 milligram. The patient didn't respond well. Then, after 10 weeks of anti-TNF therapy, because the primary consultant decided to treat him with anti-TNF, the patient developed erythematous plaques distributed on the trunk, back, and limbs. He also reported like erythematous scaly plaques with many pustules on the feet, hands, and scaling on the scalp. Patient refused to use his picture, but it was very, very, very extensive psoriasis. To cut it short, PASI was 38.4. So we know that initially diagnosed with paradoxical psoriasis, we know inhibition of TNF may stimulate the uncontrolled production of interferon alpha. So all the anti-TNF stopped, introduced the leflunomide by his primary consultant. He showed some improvement, partial skin remission. We don't know this is because we stopped the anti-TNF or because of leflunomide. Regardless, so the question here is it genuine psoriatic arthritis or this is paradoxical psoriasis more than psoriatic arthritis. Patient developed now DIPs, and this made the difference. When the patient received the anti-TNF, we expected some psoriasis, but now we have DIPs, inflammation, and swollen. This is what came to our mind, could be psoriatic arthritis misdiagnosed as seronegative rheumatoid arthritis. So our primary goal is not to treat the arthritis, is to treat the skin, because he was really disturbed. His social life was going very sharp down because of the scaly skin all over his palm, plantar, and body. So we show some slide of how the secukinumab is effective in terms of PASI clearance. We know this PASI 75 cleared up to 80%, PASI 90 cleared up to 70% till the week 104. And this is very interesting slide for the palmoplantar psoriasis. Up to 2.5 years, the patient showed great improvement, and his palmoplantar psoriasis was the main issue for this patient. Again, this patient is not anti-TNF naive, so this slide not important to me, but yes, this one is very important, anti-TNF responder. So we see if the patient failed anti-TNF, the patient may show good response in terms of ACR 20, ACR 50, again till the week 104. So the secukinumab 300 milligram showed very good efficacy in terms of skin and arthritis. So patient was started with loading dose of 300 milligram, and then we gave the usual dose of monthly secukinumab. So full assessment was done at week 12 and 16. Patient showed again great improvement. The PASI came from 38 to down to 9, and we are just happy to we showed that the secukinumab was very effective in this case. So this is what we use usually if we to evaluate our patient globally. The pain came from 7 to 3 out of 10, skin 9 to 3, and so on. So PSA is one of the score system we can evaluate our psoriatic arthritis patient from skin and joint point of view. So it came down from 7.9 down to 3. So this case is straightforward for now, but for the first case, please, if you have any suggestions, opinion, advice to how to carry on this case for the next few months or years, please let us know. Thank you very much. And I close this session. Questions? تفضل يا دكتور. دكتور رضوان, microphone, please.
So in the meta-analysis, when you showed the risk of solid malignancies, or with etanercept was 0.6,
Sorry?
the risk of malignancies with etanercept was less than secukinumab. It was 0.6.
Yes, in terms of skin.
Okay.
Yes, it was 0 case. It was about 330 cases.
What about other malignancies? Was it still less, or was it more than secukinumab?
It was same.
So why did you still go on choosing the secukinumab? Is it because you had already made up your mind to use?
Because, as I said, there is no clear data supporting or showing that there is higher risk of malignancy in anti-TNF.
Okay.
But we know all of the old reports came with link of anti-TNF with lymphoma and solid malignancy. On the other hand, we don't have that any report from IL-17.
Sure.
So we have both choice. We know both approved and both effective. So maybe I picked that choice because just I will feel more comfortable because we never heard about link.
All right, thank you.
IL-17.
Thank you.
Questions? تفضل. Microphone.
Thanks, Dr. Mohammed, for this impressive case. The first case of ankylosing spondylitis, I agree. If bus die more than 4 is mandatory, we should start biologic. And in such situation with the malignancy eradicated and treated, we could use it, as you mentioned, less risk than anti-TNF. But the problem, I think, to follow with periodic PET scan is just my advice for you, just to follow by PET scan, because can help you in follow-up in oncology patient, and in such situation, because you can pick any relapse or any primary focus or any metastasis lesion, you know, it will compare the enhancement to the liver. If the normal will be the same enhancement of the liver for glucose, if less atherosclerosis, if high, indicate this focus is malignancy.
Yeah, I agree. You mean, doctor, we have to
PET
consider
scan.
PET scan.
As periodic follow-up.
Yes, just recently, maybe this week, we announced that we have PET scan coming back to surface. So yes, I agree totally with you. PET scan maybe will help to evaluate the recurrence or metastasis. Thank you very much. Thank you very much.